I am thrilled to welcome you to today's symposium on what happens when healthcare and law enforcement overlap. My name is Eleanor Kaufman. I'm a trauma surgeon here at Penn, and this has been an area of passion and interest for me since early in my medical training, active area of investigation for the last few years. I've been so fortunate to come together with colleagues from Penn, from MedStar, and from Georgetown University to talk in depth about these issues and to put together this symposium. We hope this will be the start and not the end of a conversation about the intersection that happens between two major sectors in our society, healthcare and law enforcement. We have panelists and participants from all around the country, but I'll just speak from Philadelphia to say and to acknowledge that we're hosting this event on what remains unceded Lenape land. While I won't pretend that we can address every facet of this issue, I do believe that this afternoon brings together a really rich group of experts with varying perspectives and angles on this. Most of our speakers will be talking about emergency care. And something that I've realized as we've been thinking about this deeply is that one thing that law enforcement and emergency care do really have in common is that in our society, where we have disinvested in so many systems and structures of care and have made so many people and communities vulnerable, that many more of the challenges, particularly that marginalized people face, end up in law enforcement or in the emergency room, or both, even when these might not be the ideal systems to care for them. The way that structures of racism weigh on these dynamics mean that Black, Latinx, and Native American people most often experience the overlap of healthcare and law enforcement, as do individuals marginalized in other ways by ableism, transphobia, xenophobia, and other forces. We have found that these interactions happen in an area where there is minimal law, institutional policy, or guidance. And for these reasons, we see really important opportunities for improvements in centering and supporting patients and people at risk. We're going to hear from 4 panels of experts from different fields today. First, we'll hear from clinicians about providing healthcare in the presence of law enforcement. Next, we will hear from experts in law enforcement on reconciling the goals of public health and public safety. There'll be a break around 3 Eastern Time, and then we will learn about supporting patients through advocacy, organizing, and social services. Lastly, we'll hear from scholars from multiple disciplines on what we still know and do not know in this space. We also have 2 very special spotlight presentations interspersed from groups doing some really important and innovative work in this area. I know I'm going to learn a ton today, and I hope you will too. I'm so pleased that we have people joining us today from many different sectors and places and perspectives. And I hope you will also be galvanized to take on some of these challenges that we hear about and to continue these conversations with us, and we'll let you know how to do that, but also with each other and with your local communities. I need to take a moment to thank the organizing committee, all of whom you will see on the program today at some point: Sarah Jacoby, Utsakatri, Aaron Hall, Michael Smith, and Millie Shepard. Our sponsors for this event are the Penn Department of Emergency Medicine, the Campaign for Community, Penn Trauma, and the Penn Injury Science Center, along with, and crucially, our host, the Leonard Davis Institute of Health Economics. I've attended many LDI events in the past, and I have the greatest respect for the LDI team, but until I got to work with Rachel Werner, Janet Weiner, Tracy Chupik, and Suzanne Griffith organizing this event, I really had no idea how much thought, care, and expertise goes into putting these together. We are so lucky to have had LDI's support and partnership for this event. With that said, here's the housekeeping. There's a Q&A function on the right side of your screen where you can submit questions. We may not be able to get to all of the questions, but we will try our best. There is closed captioning of this live stream available for browser-based attendees. And to enable that, you can click on Settings on the right side of your BlueJeans screen, check the box for closed captioning, and then you'll see the captions appearing at the bottom of your screen. The session is being recorded and it'll be available in the event archive on the website at the end of this session. So I will pivot now to our first panel. We have 3 distinguished clinicians joining us to talk about providing healthcare in the presence of law enforcement. And I'm so excited to have them here today to talk about their experiences with a range of situations in which patients seeking emergency care may encounter law enforcement officers, and talk about some of the challenges and opportunities that may arise as we work to make healthcare ever more person-centered and equitable. The 3 members of this panel are Aaron Hall, who is a trauma surgeon and assistant professor of surgery in the Department of Surgery and Critical Care Medicine at MedStar Washington Hospital and Georgetown University School of Medicine, where she's co-medical director for the SICU at Washington Hospital Center and medical director for the Community Violence Intervention Program. She holds a medical degree from Stanford and an MPH from Johns Hopkins, her residency at Georgetown, and her fellowship at Shock Trauma. Dr. Hall's academic work focuses on the care of violently injured patients and on improving recovery and long-term outcomes after trauma. She's a leading scholar in the area of law enforcement and health. Tiffany Johnson is an assistant professor of emergency medicine and a pediatric emergency medicine specialist at UC Davis Children's Hospital. After graduating from medical school at Rutgers Robert Wood Johnson Medical School, she completed her pediatrics residency at Children's National Medical Center in DC, her fellowship in pediatric emergency medicine at Children's Hospital of Pittsburgh. She was here with us at CHOP before relocating to Davis. Dr. Johnson's research portfolio reflects her commitment to improving the quality of care for underserved children. Research program is focused on race and racism, impact on child health. She's currently exploring root causes of inequities in the healthcare and early childhood education settings, including research on bias and discrimination and its impact on the health and well-being of children. Kimberly Sue is the medical director of the National Harm Reduction Coalition, where she provides national trainings and technical assistance to improve the health and well-being of people who use drugs. She's a practicing board-certified addiction medicine internist, anthropologist, and instructor in the program in addiction medicine at the Yale School of Medicine. Dr. Sue is a graduate of the Harvard Medical School's Social Science MD PhD program and completed her medical training at Massachusetts General Hospital. Her book, Getting Wrecked: Women, Incarceration, and the American Opioid Crisis, uses a medical anthropology lens to examine the intersection of U.S. prison systems, addiction policy, mental health, and drug treatment for women in Massachusetts. She's worked in diverse clinical environments, including syringe service programs, methadone clinics, and the Rikers Island jail system in New York City. I am so happy to have Dr. Hall, Dr. Johnson, and Dr. Sue with us today. Welcome. And I'll start by asking you each to talk about what draws you to this area of interest. How does law enforcement presence impact your clinical care, your clinical practice when you're taking care of patients? And if you want to share a patient story or anecdote that encapsulates some of this for you, that would be great. And I'll ask Dr. Johnson to go first, if you don't mind.
Thank you so much for having me. I'll say, as you read my bio, so in my background, I've always trained and previously worked in freestanding children's hospitals. So I think this really came to my radar when I changed into a system where I'm in a general emergency department now, and law enforcement presence is just so looming in a way that it has never been for me before. So working in freestanding children's hospitals, my typical engagement with law enforcement was in a partnering role to protect children. So I'm a mandatory reporter, and we often evaluate children for suspected abuse in the pediatric emergency department. And so law enforcement was our partners for really protecting children and keeping children safe. Now that I'm in a general ED, there's not a shift that goes by where I don't see law enforcement walking down our halls with their guns or in our cafeterias. Their presence is just a lot more prominent in the general emergency department. And there are a couple of recent encounters that I've had that really kind of helped me see some of the negative impacts of having law enforcement in our ED. So one quick story was just a few weeks ago. I had a teenager, I see up to 21 in the pediatric side of the emergency department. So she was maybe 18 or 19 years old, who came to the ED for evaluation after being assaulted. And before the medical team got in to evaluate her, the police went into her room to kind of question her about the events. And so by the time we got into the room, they had already accused her of being a prostitute. And she felt very blamed and shamed in the situation. And so it really eroded that therapeutic environment before we even had a chance to interact with her. When law enforcement is your first point of contact in the healthcare system, then it makes it challenging for the rest of the interaction. And so for me, it's important to think about how do we keep our patients safe and how do we keep our staff safe, and how do we make sure that law enforcement are partners for us in protecting our patients, but doing it in a way where we're not inadvertently causing more harm and causing more trauma because of the presence of law enforcement in the ED. Another quick example that I'll share that has been really pertinent for me was a few months ago where I had an adolescent, 12 years old, was involved in an incident where accused of a nonviolent crime. He and his friends were running from the police, and the police sicked their K-9 unit police dogs on him. He was the youngest and the slowest, and so he's the one who got caught by the dog, and he sustained pretty severe injuries, so severe that he had to go to the operating room to have those injuries managed. And so now I have this kid, he's 12, he's in my emergency department, he's scared. he's injured, he's in pain. And social work is usually our connection for when children come in unaccompanied by their parents, to contact the parents so that we can let them know what's going on, get them to the ED, and kind of have some shared decision making around their treatment. But when my resident contacted social work, she was told, well, he's in police custody, so we can't call his parents. And so I go to the cops and I say, hey, listen, this kid is going to the operating room. I'm the doctor who's leading his medical care. I need to be able to speak with his parents. And they said, oh, don't worry, we're going to just release him with a citation. You can feel free to contact the parents. So this was alarming to me for a couple reasons. Number one, why did you release a canine on a child, resulting in injury so severe that they have to go to the operating room just so that you can give them a citation and release them to his parents? So it was a good example of the way in which we see unnecessary violence towards children when they have interactions with the police. But number two, the fact that I had to go through the police officers to get permission to be able to contact his parents is another challenge that we have kind of at the intersection of hospitals and law enforcement. So our hospital, similar to many hospitals across the country, have policies around patient confidential status when they come in with law enforcement or when they come in as victims of violent injury in the community. And those policies are intended to protect patients and to protect staff. But as a pediatric provider, I've seen many situations in which it has unintentional consequences. So in my situation, I was allowed to contact the parents, but I've had colleagues managing critically ill children who come in as victims of violence. And because the patient is under a confidential status to protect them, we can't contact their families to have them involved in care. So those are just a couple of examples. And I'm here to share some of my stories and perspective, but I'm really mostly here to learn what can we do as advocates for our patient populations to ensure that our hospital policies are, again, keeping patients safe and keeping staff safe, but not inadvertently causing more trauma and harm.
I'm so excited to hear you all respond to each other and have this conversation, but let's go around the rest of the panel with kind of the same type of background information. Dr. Hall, answer the same questions. What are your considerations, and maybe what are some stories that come to mind?
Yeah, I think so. I'm a trauma surgeon. I am lucky enough to be in sort of a trauma receiving unit. So only traumas come to me. It is my dream job. And for so many years, we had a very typical situation, we still do, where police will accompany victims of violence into our trauma bays. And there are lots of different reasons for it. And I've asked, and those reasons stem anywhere from that person is a known suspect and in custody to a gray area where the police or law enforcement genuinely don't know what the situation on the street is. A lot of it is also for our own protection as staff members. But those 30 seconds or 30 seconds to even 10 minutes to 30 minutes while we are doing our trauma work are, no matter how we present it or what we do, it's a re-traumatization. I mean, we pull them in, we're over on a bed, we strip them naked, we are yelling questions at them, all with the patient's best interest in mind. I mean, we have been trained to do this, we are in our element. But at the same time, I just started to question or started to look at that situation and say, this is protected health information that we're extracting or that we are displaying. What is the role of law enforcement being there? How, when we have this whole spectrum of people coming into our ED, why are we treating them all exactly the same? And then what about the other people in our trauma base and the information that is floating around about them? There's some sort of, we are, as medical professionals, just drilled into our minds about patient privacy, about autonomy, about what true informed consent is. And I just started questioning, what is really going on here? And I have to be honest, for a long time, I just sort of thought, well, somebody's thought of this, clearly. I'm just a young trauma surgeon doing my thing, and I don't need to question this again. I'm sure somebody is. And when I just poked at it even a little bit, it's pretty clear that not a lot of thought has been put into it. And so for me, that just seems like, wow, what an opportunity to really like sit back and say, what would be the ultimate patient-centered thing? What would be the ultimate public safety-centered thing? How do we keep our nurses safe? How do we keep me safe on the front lines? But how do we do that in a way that's respectful to everybody involved? So that's how I got involved, and I'll leave it to Dr. Sue to take on the question.
Absolutely.
So much, yeah. I come at this from addiction medicine standpoint and also as a harm reductionist, and just taking care of people who use drugs in hospitals and realizing the ways in which hospitals can be very similar to carceral institutions, to prisons and jails, ways in which they feel like that. And so, qualitative research really has shown us that people feel like they are in total institutions. So thinking about not only the ways that police and hospital security that are ostensibly there for our safety, patient safety, public health, and community safety, ways in which they can do psychic and also physical harm and violence. And ways that we ourselves participate in the criminalization of patients, and all of us in many ways are complicit. Thinking about language, thinking about what we write in the words and language that we use in our notes, ways we look at people, our tone of voice, our attitudes, and our floor policies, and participate in policing. So many patients have told me that these policies of being strip searched, these policies of having their belongings searched, these policies of having visitors restricted, all of these kinds of policies do create an environment of policing and surveillance and harm, and many times just trying to balance the safety and of people who are patients and our safety. But again, these are real difficult struggles. I'll tell the story of a patient on the addiction consult service that I saw who was having some difficulty with pain management. He had a long history of opioid use disorder and was trying to get workup of osteomyelitis or endocarditis, and really needed to be there. And unfortunately, got into an altercation with staff and police, hospital police, pepper sprayed him and 4-point restrained him. I'm not sure. It was quite hard to deal with that, and hard to think through as a healthcare system. Are we really creating like Dr. Johnson and Dr. Hall said, are we really creating a place of healing, treating people with dignity, respect, and safety when we end up with escalating behaviors from and participate in that escalation as staff members?
Thank you so much. And I think you're all kind of picking up on something that's not necessarily my favorite thing to think about as a doctor or as a healthcare provider, which is the ways in which our practice and my practice does violence to patients and to people, right? And the different kinds of harm that we can inflict, even when maybe we have the best of intentions. Maybe we don't always, but often we do. I'm going to put this question first to Dr. Hall, and you kind of headed in this direction, but how do you all think this impacts patients' experiences of care, or even their outcomes, their health?
Yeah, I think that's a really important question, and Dr. Sue mentioned this too, and Dr. Johnson, of this idea of physical harm that can happen to patients and escalation of care. I think there's that component to it. Even more than that, what we see, or what I see, is a loss of that patient-provider relationship and trust, and that can lead to decreased communication, withholding of important details for their medical care. It can lead to decreased utilization for emergency services. We also see it increases barriers to access for our patients. There are higher levels of AMA that's leading against medical advice. But I think also law enforcement presence and those gray areas can increase provider bias and can increase discrimination of the hospital system for these patients. There's some studies out there that people who have a law enforcement presence nearby will have decreased tests drawn, will be seen less often by a provider. And I think it's really interesting to me also how our relationships with law enforcement and can increase even risk for arrest or risk for incarceration along some common practices of even like running a name or different things like that. And so if we are complicit or we are seen as complicit, I think it really erodes some of the fundamental relationships, but then also like fundamental access and fundamental care that our patients can receive. And that's been borne out in research.
I think I've probably seen, our practices are pretty similar, and I think I've probably seen some of that. Is it the same for the children you take care of, Dr. Johnson?
Yeah, I would definitely agree that there is a stigmatization of patients when they come in at the hands of law enforcement. And, one of the things that struck me was a comment Dr. Sue made about the ways in which kind of our biases are manifested, and it can come out in how we communicate with patients, how we document. And so there's actually literature that shows that when you use stigmatizing language in a medical record, it impacts the subsequent providers who are caring for those patients. So when we do our notes and when we do our documentation and we use certain kind of language, the next people who are evaluating and taking care of that patient, they read that and it biases how they treat their pain and how they manage them. And so I do think it's important to think about the ways in which we are criminalizing our patients in the healthcare system. And it's also, Dr. Sue also talking about harm reduction, which is interesting to me because I know she was using that in the context of substance use. But it's also important for us to think about from a healthcare perspective, how can we have harm reduction, right, in the ways in which we're interacting with our patients at the intersection of law enforcement and patient care.
Yeah, I mean, I think what worries me the most, and both of you touched on this a little bit, is how this stigmatization plays out in terms of ability for people to trust us and come back to us. I think about many people that don't show up to the ED with sepsis, with endocarditis. They'd rather die than come see us. Like how those interactions, the way in which people are treated on a fundamental level really impacts their ability and interest in seeking care and seeing us as a place of safety where they can be treated with dignity, respect, and compassion. And so that is really something that I think about a lot. And for the people who don't and won't come to see us because of those previous interactions, I think also that the impact of having police and with that also, I want to mention the widened carceral net of probation, parole, people on ankle bracelets, and the ways in which that I've seen that change our management directly from an addiction standpoint. If people are on certain medications and they have to go right back to a facility that doesn't offer that medication at this time, like that's not what the patient wants. That's not what I would want, but we go with a medication that is available to them at that time. So it really is a hindrance to us to have to think through all of these extra layers when people are under, under arrest or they're under, or we're going to discharge them to a facility that's a carceral institution. So I think that that many ways can harm them, and ultimately trying to have that follow-up and trying to think through all of those things complicates the optimal evidence-based care that would be informed by ideally be informed by the patient and me, without the structural constraints of what is available to them at jail.
The other thing I'll add is that we've been discussing mostly law enforcement in terms of community law enforcement and their presence in our hospitals. But I think that we also need to take another look at our own hospital security systems and police forces that are present within the hospital. So, last summer there were lots of protests, including, White Coats for Black Lives regarding police harm caused in the community. But we have not, as healthcare systems, really kind of taken a look in the mirror at the ways in which we can cause harm in terms of the way that we use security guards and police officers within our system, including, literature that shows that Black and Hispanic patients are more likely to have security calls. And again, thinking about the ways that results in your patient experience. And again, I'm a pediatrician, so, parents can't really just say, I'm going to leave against medical advice when my child is here for, a critical condition. And so we kind of almost in some ways hold them hostage and incarcerate them, right? Forcing them to receive care in an environment where they are not respected. And there are so many ways in which, when a white parent advocates for their child in a certain way, we feel the need to try to appease them and to satisfy them, to try to make sure that we have good press gainies from them. But when parents from more marginalized or stigmatized groups try to advocate for their parents, then there are many times in which we weaponize our power and privilege as healthcare providers in contact security and contact law enforcement, which definitely erodes that therapeutic relationship in the healthcare setting.
Dr. Johnson, I wanted to go back to something you said at the very beginning, which is that, in working with children, maybe this was more true in a pediatric only standalone hospital. But there are times, right, when the police are your partners or when law enforcement is involved in the things that you need to do for a patient. I'd love to ask you to say a little bit more about how you've seen that, if there's times when you've seen that work well and what you think might have contributed to that. And without getting too far into the medical weeds, but a little bit into the medical weeds, I'd love all of your perspectives on mandatory reporting and the myths and the reality and how that plays in.
So I definitely think there are times where that relationship works well. So we are mandatory reporters. So if a child comes in for suspected abuse, and particularly when kids come in with severe injuries, law enforcement are our partners in helping to make sure that we are going to be able to keep kids safe, so that we can, prosecute those individuals who have caused harm to those patients. But I think, Dr. Hall brought up around how our own biases can come into play when we're making some of those decisions, though. So, I've had examples of resident physicians telling me, oh, yeah, I was on an inpatient service and we had two patients, both who were admitted for accidental ingestions of cannabis edibles. And one family is white and one family is Black, and we're calling Child Protective Services and criminalizing it in the Black family, but not. And they're literally there for the exact same thing on the exact same team. And we just have so many blind spots around who gets criminalized for those behaviors. And similarly, when it comes to child abuse, there's lots of literature documenting that when young children who are under 2 who can't tell us what happened present with injuries, we're much more likely to do skeletal surveys and reporting to Child Protective Services, which sometimes gets law enforcement involved for Black children in comparison to white children. And so that results in these bi-directional disparities where we're sometimes missing abuse in white children and sending them back home to the individuals who are abusing them. But then we are unnecessarily working up kids and getting them caught up in the criminal justice, getting their families caught up in the system, who are presenting with injuries that are clearly accidents. And so I think that we need to make sure that we're kind of being mindful about our biases and the consequences of it, right? So missing abuse definitely has dire consequences for causing further harm to children, but getting them caught in the system, right, and filing reports also can cause lots of harm to the families who are involved.
If I can just jump in there a little bit too. I mean, I think along these same lines, when there's the least amount of tension and the most amount of partnership and working together are when things are very clear and they're applied across the entire, to everyone. And so and it takes, as a, we all respond to emergencies. So when you're standing at 2 a.m., like it takes a little bit of that, like, I just don't like the way you're acting, moving, talking, whatever. And it's like, nope, actually, if you had showed up at 11 and I was in a great mood, this would be the exact thing that happens. When you show up at 2 a.m. and I'm in a bad mood, this is the exact thing that happens. Our interactions are controlled and in a thoughtful way that we are both expecting. And that's when I feel like the partnership is really fantastic and the communication is great between law enforcement teams and healthcare teams. And what I would say about mandatory reporting is that it's presented as, I think as a non-pediatric practitioner, we were always like, okay, there's like child abuse and elder abuse, and these are your mandatory reporting. Many other places have mandatory reporting for violent crimes, but those aren't really explored, taught, educated. So there's an incredible amount of just catch up that we need to play about. These are the policies that exist. These are who they apply to. Again, it's nothing personal. It's not like, but we have decided that these are the people or these, are the victims that we're required and obligated to report on. And actually the information that we are not obligated to report, we shouldn't be reporting, or we shouldn't give, that there are other ways to proceed with investigations that honor patients and their ability to consent and informed consent and their autonomy much more than us giving away their protected health information.
I'm going to pick up on a couple of audience questions that also dovetail perfectly with the next thing that I wanted to ask, which is, maybe I'll do two at once and say, what strategies do you have directly when you're doing patient care, interacting with a patient and law enforcement is present? What options do you have? And then maybe to take a step back and say, what strategies or tips or successes, and this is something we're going to be hearing about all day, I think, you have in advocating within your systems where you work to support patients in these challenging situations. Maybe Dr. Sue, since we skipped you on the last
one. Two questions. It's hard for me to keep two questions in my head at once, so I already forgot the first question. But
the first one is, how do you do it? How do you navigate patient care? What kind of strategies do you use?
So you're in the yeah. Okay. So if there are police or people who are in custody, I really do try to establish firmly that I want to be alone.
Somebody didn't like that response.
Oh no, is that Dr. Sue's connection? Oh.
All right, we'll get her back, but that means one of you has to answer.
It means we're on the high. Oh, here we go.
Oh, she's back. Go for it. You disappeared there,
okay.
Kim.
Okay, I saw a big yellow bar. So if you're in the room, obviously establishing, trying to, really being firm and adamant with police or other guards that you want privacy, and that's kind of essential for me, especially since I'm talking about substance use and a variety of other things. But I'm sure it's you guys in the ER and in trauma, it might be slightly different depending on your environment. I'm usually in the inpatient or sometimes in the ER, which oftentimes, sometimes I'm in the hallway, but really trying to create as safe a space as possible. And really just treating, this is basic, but, allowing, patients to have control over the decisions as much as they can in that environment. And like Dr. Hall was saying, I think some solutions include standardization, even within your own hospital, within your own floor, depending on where people have been before. Where I train people be like, I want to go to like white, or I want to go to like, 9, not 10. And, and that is actually like not ideal, right? Because there's You really want people to be able to go anywhere and be treated with dignity and respect and have those things. In fact, at so many hospitals, they say things like, oh, is there like a place, maybe we should start like a floor for people who use drugs, and because like they would be treated with dignity and respect and compassion by people who are trained and want to do that. And it's every hospital I go to, it's brought up, and it's always kind of for various reasons. It's including increased stigmatization and other things. It's not really enacted. But really, even if people can leave the floor for smoke breaks, like that's not even standard, or it's not standard in practice. Or what happens if someone's suspected of using drugs? That's not standard. Is it standard to call the hospital security and search items as a standard, or is that only applied to people who are Black? I mean, these decisions taking them, you can have a policy on paper, but then people really need to enforce it. And I think the third thing I'd say is there's also community groups. Like there's a wonderful group called Movement for Family Power in the Bronx, and they've been working on trying to create legislation, against urine toxicology on labor and delivery floors without consent, because that ends up being part of structural and institutional racism, right? Where, so they are actually trying to pass legislation. So it goes even farther than our hospitals and our own hospitals and policies, but into our communities, and trying to create better change across our systems.
I think for me, I mean, I have to say for a long time, I don't think I navigated the relationship very well at all. And I sort of took the path of least resistance and this sort of idea of like, well, I'm like saving someone's life right now. Like this probably, this is on the back burner, or like when I have more energy, or when like and I just started realizing like how for so many people that honestly don't look the way that I look, it can't be on the back burner, and that it is a constant source of stress and an impact on their lives, and something they are constantly aware of. And so for me, the breakthroughs that I've made both on my institution level and then also just on my clinical care level has been to really try to partner with both law enforcement and with my patients. And I run the violence intervention program. I'm a medical director, and really listening to my violence intervention specialists about what are the feelings, what are the things, what are the points of tension or question, and then really try to bring it back to what are our core principles, or how do we navigate these things from just an ethical basis of like, justice, of beneficence, of autonomy. How do we and these things that guide all of us, or, in our best moments guide all of us. And then how do we work that back into the fabric of how we take care of patients? And I think that has a lot to do. I'm a big policy person too. So saying like, why don't we bring everybody to the table, look at like what is actually happening, acknowledge it, and then say, okay, well, what is the ideal? And take back a little bit of control of that space and say, like, as doctors, as the hospital, even as the institution, like, this is our property and our space, and we have the right and the ability to make policies that also don't have to hamper law enforcement. We also have an obligation to public safety, and we have an obligation to a sort of greater good. So how do we work together with law enforcement to say, like, we both work under law, like, how do we make that law happen in the hospital? And then even within the hospital, how do we make policies that really make it a healing place, and a dedicated place for our patients, all of our patients?
And so I'll agree with all of the strategies that have been outlined by Dr. Hall and Dr. Sue. I also really like to make sure that I have time to interview my patient, get the history, talk to the family without law enforcement in the room. And during that time, I focus on a couple of things. One is explicitly letting them know that my top priority is their health and their well-being, so that is at the center of the interaction, and really just taking time to try to humanize them. Particularly when it comes to patients who are coming in, typically young Black males as victims of community violence, and they come into our system and they're immediately criminalized and thought to be gangsters. And so I like to take the time to say, like, hey, buddy, like, what get to know their name. What do you like to do? What's most scary about this? Like, what are your biggest goals? And it really just helps me to see them as people and not as statistics and not as like the GSW and Trauma Bay 2. And it helps them know that, like, I see them as a person. And I think that really goes a long way in a therapeutic relationship where we really just like humanize our patients and decriminalize them. In terms of beyond the individual level, but like the hospital system level, I do think it's really important for us to evaluate all of our hospital policies, particularly those around kind of law enforcement, with a health equity lens. I think we in healthcare systems have had a colorblind ideology when it comes to our approaches to things, and being colorblind causes harm. And so one example of a win that we've had within our healthcare system was last year, just on the heels of all of the protests around the murders of Breonna Taylor and George Floyd, Elijah McClain, and so many others. The UC Davis Police Department decided to start a canine unit and have a police dog patrolling our emergency department. And so I'm sure you guys can imagine the challenges associated with that when it comes to the history of canines being used as instruments of terror and oppression in Black communities. But also when thinking, you have Dr. Sue on the call for patients who come in with substance use disorder. And when you see a police dog, you may have some fears that, oh, this is a drug sniffing dog, and are they going to find drugs on me? And is that going to result in me being arrested during my encounter? So we, several individuals on our department diversity committee kind of came together with a strategy, and we escalated it to our ED leadership to outline the potential harm and unintended consequences of having a police dog patrolling what should be a therapeutic environment. And I'm happy to say that we were actually able to get the police dog removed from the emergency department. And so that was a win where we were really able to advocate for our patients. And I think that there are lots of other ways where we need to think about what are some of those policies that are causing harm and what can we do to adjust those policies.
Yeah, and if I could jump in, I mean, I would say not only the policies, but the sort of rumored policies. So the fears, the stories, the cultures, the practices, God knows, I pay attention when my, experienced trauma nurses say something, but they also say a lot of things that are like, well, we always do it this way, or like this, and I'm sure they've saved lives by saying some of those things to me, but some of them, it's an absence of policy, or it's a habit, or it's somebody sometime thought this was the thing to do once, and now it's become what we always do. And so I think there's a large vacuum often, and that policy might not exist, or might be silent, or might be not actual policy, but really just practice or stories or culture. And these are all things that are difficult to change, but it's possible to change them. These are, I think there was a question in the chat about kind of differences between public and private hospitals. And my guess is that a lot of the differences you see are actually just even more vacuum of policy, not even policies that exist, but ones that don't exist and have become just practices and common relationships. Again, difficult to change, but not impossible. So gives me hope.
And related to that, I would say policies that are created based on rumors and speculation. And so, even when we think about these confidential status policies that result in restricted visitors, I'm like, where does that come from? Other than Jason Bourne movies, when does somebody get shot, right? And then the person who shot them comes to the hospital to finish the job, right? If I were trying to kill somebody, which I wouldn't be, the hospital wouldn't be the place for me to finish the job, right? You're not going to go past security and go past, metal detectors to go to the hospital. You're going to wait for them to come back to the community, right? So these policies that were developed to protect patients and to protect staff, it's but do they are they really needed?
Yeah.
Like, when has it ever happened that somebody has come to the hospital to finish the job? So thinking about like where these policies are born from, and how we can reevaluate them in ways that again are protecting patients and protecting staff, but aren't based on these legends of what could possibly happen that are not based on any facts or truth.
Yeah, and I think even more than that is like, why don't we gather evidence? Like, how many times has that happened? I think when we ask our patients to weigh the risks and the benefits of a procedure, we try to present them with the evidence that we have. We have evidence that handcuffing patients or putting patients in orange gowns like increases bias and discrimination and decreases patient-provider trust. Do we know if it also decreases risk of flight or decreases violence between, if it increases security and safety of staff? I'm not sure we do. It's a really hard thing to study, but I think it's worthwhile to study because at least then we can be informed about our decisions and we can say, okay, there's this harm and there's this benefit. Here are the values of those things. Which way are we going to go? Like, we have a decision to make. So I think you're absolutely right, though. These sorts of stories or what ifs that happened, and the amount of control that they have over our lives sometimes, or what it feels like, is really remarkable to me.
I'm going to pick up on some of that and on a couple of audience. There's some really good questions coming in. I don't know if I'm going to get all of them. I will highlight one person who was looking for the perspectives of law enforcement, and I'd say you're going to get some really good information about that in the next panel, so stick with us. But a couple people have asked versions of this question about sort of what is my authority as a healthcare provider or as a physician? Are there risks to me, legal risks to me or to my hospital if I want to say a better word, but I'm the best I can think of right now is interfering in some way or kind of getting in between the law enforcement officer. Where does my position supersede law enforcement, or what do people need to be worried about? We can talk about that now. We're going to talk about that again right after this, but I think it's on a lot of people's mind.
I think for me, I try to really take a patient-centered approach, and not a me-centered approach, and think about, yes, there is the concern about interfering with law enforcement, but what about them interfering with patient care? And so I really try to focus on, as a healthcare provider, my number one priority is the care of this patient, and making sure that law enforcement does not interfere with that. So that's the approach that I take. That they're gonna have their time and they're gonna have their turn. But when you're in my emergency department, my priority is your health and your well-being, and I need to prioritize your care over everything else.
Let me preface this with, I am definitely not a lawyer and I have just gotten into this field. But really my understanding is that in both court cases and then also otherwise, the medical emergency and therefore the doctor and the practitioner has the sort of power in the situation or has the decision-making ability to say like, nope, the physical condition, the physical safety, these other things come before any kind of investigation or before your presence is allowed here. So my understanding is that doctors in general have that ability to put barriers or to intervene and have not been, the consequences have not been legal about that.
I think another thing that, I completely just want to build off of those two things, which I would have said if you guys didn't cover that, but if we ourselves are concerned about our own safety or something feels off, I would much rather go in with my team, with my nurses that I know and trust, or my team, than have an officer there. It may seem obvious, but I do love to envision a world where we don't have law enforcement officer, where we don't rely on, law enforcement, and especially in our hospitals. So ways to re-envision safety, to actualize places that are safe, that we can provide, and that's not always possible. But I mean, I think in many cases, I think some of the questions are like, am I empowered as an intern doctor in the ER? And we're trying to, I think, we all feel like you are, and you should be. I think I would refer to your hospitals, like, when people come in anyways, they sign a bunch of, privacy things, and hopefully, that protects you and them. And even places, have like patient bills of rights, that should outline, that privacy is really paramount, and ability to have, a safe and secure conversation and examination with a physician is one of the quintessential parts of creating a safe space as a hospital.
Yeah.
Related to that, I'll say that, we talked about mandatory reporting, and we get lots of training on mandatory reporting, but we don't get lots of training on interaction with law enforcement, and what information we are allowed to divulge and what information we can't because of patient privacy issues. And so I think a lot of those breaches of confidentiality happen not just because people don't know, right? And they think they're doing the right thing, and they think that they're trying to help. And so I think a lot more education needs to happen within the healthcare setting on. So again, like Dr. Hall mentioned, we want it to be standardized when patients come into the emergency department. So how do we have clear policies and procedures, and educate all of the staff, and including nursing, including the people who are at the front desk, as well as the physicians, on what those policies are, so that we're not breaching confidentiality unintentionally.
Yeah, I mean, I think what's remarkable to me, and I had no idea even as a trauma surgeon, is HIPAA. I mean, how often have doctors at least been like drilled about HIPAA, and how many PowerPoints have we sat through about HIPAA and different things like that? But has specific carve-outs for victims of crime. And so in this case, there's actually a higher degree that you have to meet in order to give away protected health information, or in order to have those disclosures. So there's actually quite a lot of protections for physicians, but even more than like the laws and the policies that may or may not exist, I think there is a baseline expectation that patient's health is your priority and your prerogative, and actually takes primacy over any other situation that's happening. And so you have that power to make those decisions in good faith. You will not be perfect every time, but these are good faith decisions. And I just want to encourage young practitioners, but also all of us that have been doing this, that, I mean, we can regain this, and it doesn't have to be adversarial. It's not personal. It really is about patient care. And I've been just so interested in, and I feel so fortunate to have a good partnership with MPD, and to have, be regular meetings and talking about all these issues, because in a lot of ways, that overlap of like what law enforcement wants and what we want are similar. They're not so disparate that we can never partner, or we could never understand where each other are coming from. And when we have a shared understanding of the importance and what the things are, we can move forward, and we can provide better care, I think.
So that's a perfect transition toward wrapping up this amazing first panel. I'm just looking through some of the questions from the audience, and some of these are things we're going to continue to address throughout the day. And I'm really excited. One thing that we're not going to spend, that we don't have really covered today, is the complicated dynamics in terms of maternal health. But I'm so excited that Dr. Polite is here, who's the chief of OBGYN here at Penn. And she points out something that I think is broadly relevant. She says, Dr. Johnson mentioned consent, or someone mentioned consent for drug testing on labor and delivery. And she says it's not just consent, it's creating guidelines for who is even asked. so that racial biases don't become the norm for who is getting the urine toxicology in the first place. And that really kind of that speaks not only to how broadly these issues come up, but also to we've talked a few times about systematizing and standardizing our practices, but how far from simple that is. But in that spirit, in that policy spirit, with our last 5 minutes, I'm going to ask each of you to say one thing, or if you can squeeze in more than one thing, that's okay. But if you could make a change, if there's a change to policy or something new that you would do in your institution or more globally, what would it be? Dr. Johnson.
I co-authored a commentary that was recently published in JAMA Pediatrics on the harmful effects of policing from neighborhoods to hospitals. So we have probably about a half a dozen recommendations there. But if I had to pick just one, I would, like, in the utopia world, it would be weapons-free hospitals, right? Like, I would love a gun-free America in general. But if I can't change anywhere else in the hospitals, I think that it should be a therapeutic environment that is weapons-free, including tasers and guns and K9 units. And that is both for our hospital security as well as law enforcement when they're coming into our healthcare system to access it. And I think that there have been a couple of recent cases that have made the headlines and news that highlights the importance of this, including police officers or hospital security critically wounding or even killing patients. And so that's something that should never happen. You should not be in the emergency department or in the hospital being treated for a psychiatric illness and being criminalized and sustaining harm in the form of getting shot by law enforcement. So that would be my pie in the sky. No guns in hospitals.
Dr. Hall.
Yeah, I'm going to say just empowering practitioners to take control of that space again. That's a very trauma surgeon way of looking at it, but I think that's what really that's what my wish would be. And then not having to do it alone, right? Because these are super complicated questions. It is hard to break out of your own experiences and your own viewpoint. So then, being able to use guidelines or best practices and having them exist somewhere that other people have thought about and looked at and examined, and then making it standardized not only in your own little silo hospital, but can we do that across the country? Can we talk about what are best practices between trauma units and law enforcement? What are the most protective practices for mental health responses for incarcerated patients that come into the hospital? Like, these are not uncommon incidences, but there's just, when you dive in and start thinking about it, you feel very alone. And so we don't have to be. We can pool our resources and think together. So that's what I would wish for. Empowerment of the doctor, the medical team, take your space, but then also strengthen numbers and really thinking about this, trying to think about it wisely.
Last but in no way least.
Okay, 1 minute. Building on that, I'd like to address the gnarly kind of culture issue, and so thinking, for example, about urine toxicologies, who gets them, in hospital substance, in hospital drug use, which addiction is a chronic condition that is expected. How do we deal with those things? And encouraging students, trainees, attendings, we need to kind of think about these as M&Ms and think about, ways that we can look and identify upstream structural racism, institutional policies. How is it different with our nursing staff, who often feel like they're the ones who are, have to police, while the doctor comes in and is like, oh, whatever, and the nurse, so this is really like chaotic here, and so like really working in a truly interdisciplinary fashion with our colleagues, and bringing these cases up, like Dr. Holland Johnson said, these are happening all around the country, and your experience with an officer and debriefing that with your team and trying to create education around that on both like a micro to macro level.
Awesome. Thank you all so much for being here and for getting us off to such a good start. Thank you to everybody who's listening and who's asking questions. There's some great questions in here that I think we're going to continue to get to about mental health and all kinds of other things. But thank you so much.